Dear colleagues and friends, I would like to welcome you to this video podcast on the updates of the EAU Guidelines on muscle invasive and metastatic bladder cancer. I'm Tom van der Heijden, I'm urologist in Nijmegen, the Netherlands, and chair of the guidelines. And with me are Laura Mertens, urologist from Amsterdam, the Netherlands. Welcome, Laura.
Thank you.
And Mariappan from Edinburgh, urologist as well. Welcome.
Thank you.
So, Laura, let's start. Regarding imaging, are there any news?
Not really. There's not too much news in the 2025 guidelines. The recommendation for local staging has changed a bit. So it now states that if you perform an MRI, do it before TURBT. For distant staging, a CT scan of the chest and the abdomen is still the recommended form of staging. There is a statement about FDG PET-CT that it can be of additional value by detecting additional lymph node or distant metastasis, but that's based on actually one large study, so that's not a recommendation at the moment.
That's the study with 700 patients. Actually, that's a study from Amsterdam. And it was proven that it made a difference in treatment strategy. And it was about a quarter of patients.
20% of patients got a different treatment because of additional findings on PET-CT.
But for the rest, there were no new manuscripts regarding FDG PET or PET MRI?
Some new manuscripts, but nothing really that changed the guidelines. So the recommendations are still more or less the same.
And is there any news regarding oligometastatic disease and the treatment of it?
Well, oligometastatic bladder cancer is defined as bladder cancer that extends beyond the bladder, but that is limited to a maximum of 3 metastatic sites. And that's based on the recent consensus statement. For other malignancies, you see a growing interest in aggressive treatment of patients with oligometastatic disease. Also for bladder cancer, there is some evidence, some additional evidence showing a potential benefit for treating the metastasis surgically or either with stereotactic radiotherapy.
And are you referring to the German study?
Yeah.
The German study where patients had a metastasis, were scanned, and they wait for a couple of months, scanned again, and if that were the only lesions, they removed it surgically?
Exactly. Still, I do think it's important to mention that this is all based on a limited amount of evidence, and it will remain a topic of debate, especially within the field of new systemic agents.
Yeah, but they had fairly a good overall survival benefit.
Yeah.
It was around 20 months.
Yeah, exactly. So it is something to consider in real oligometastatic disease.
Yeah, and do you think it will change because those patients were treated with neoadjuvant chemotherapy, or chemotherapy actually, and afterwards they were treated surgically? Do you think it will change in the current era with pembrolizumab or enfortumab vedotin?
I think for metastatic bladder cancer, systemic therapy will remain the first choice. I do think that if a patient develops a recurrence a long time after a good response to systemic therapy, oligometastatic treatment might be a good option.
So Laura, thank you. So the recommendation is to perform a standard lymph node dissection?
Yes.
Are there any other changes surgically per arm?
Absolutely. I think there's been, along with the change in focusing on TMT, for instance, in the patients who have cystectomy, particularly in women, it's very important to respect their bodies and their desire to maintain function. And preserving the organs, particularly the uterus, the blood supply and the neurovascular supply to the sexual area is hugely important. Whilst there's no level 1 evidence to really support it, there's a lot of biased papers here and there. However, it's an important principle that where possible, and if you're confident that you're able to clear the cancer without leaving any possible microscopic disease in the organs that we preserve, organ preservation should be the way forward. And our recommendation is quite strong about it in the guidelines.
That accounts for women and in men?
And in men, I'd be slightly dubious because you're worried about leaving the prostate behind. There's a risk of prostatic urethral disease, and we're not very good at diagnosing that, even at the time of the TURBT and the initial assessment. So the clear concern is microscopic disease, not only in the urethra, but also in the stroma of the prostate as well. So I'd be a bit more cautious about that.
There's a French study saying that 30 to 35% of patients have localization of urothelial carcinoma in the prostatic urethra.
Exactly.
So we recommend to do a sex-sparing operation in men when they are very well motivated to keep their sexual function.
Exactly. Counseling is critical in both men and women.
Yeah.
Yeah, and don't forget to think about sexual preserving options in women, indeed.
Yeah.
It's a major change.
Yeah.
And Param, what do you think about the trimodality treatment? Is there any news regarding that?
There are lots of studies that have come out of the North American groups, particularly MGH and Toronto. You know, the Zlota paper, which is really groundbreaking, I would say. I mean, short of in the absence of level 1 randomized controlled trials. So I think we are moving into a frontier of both organ preservation in the surgical aspects, as well as preserving the bladder itself in trying to undertake TMT. So I am a strong advocate of us trying to consider any form of organ preservation, which includes the bladder.
Yes, and let's go back to the Zlota trial, because it was the disease-free survival actually was the same in both groups. The groups treated with radical cystectomy and those were treated with trimodality treatment.
Yes.
The overall survival is even better in patients treated with trimodality treatment.
Yeah.
But looking more into detail in that study, the majority of patients, 90%, had a T2 tumor and only 10% T3 or more.
Yeah.
So it might also be a kind of...
It's going to be a selection bias. Then.
Exactly.
Yeah, I know. We tried to recruit into a study called SPARE in the UK to randomize patients to have radical radiotherapy, a TMT equivalent versus radical cystectomy. It was not possible. It was not feasible to recruit. So short of doing
and that was a study randomized trial, so patients didn't know what to get?
Exactly.
Yeah, but
exactly. Patients would not want to have that lack of choice.
No, and you can imagine, of course. For the trimodality treatment, patients can't have extensive CIS, but in this Zlota trial, hydronephrosis was allowed. What is your opinion about hydronephrosis and trimodality treatment?
It's going to be difficult because obviously, as you know, there's going to be scarring following the radiotherapy to the bladder. And it's likely these patients are going to have either a stent or a nephrostomy. And that's going to be quite difficult to manage. So throughout life, they will have some level of effect of their quality of life. So I would probably suggest those patients should be considered for cystectomy. It'll be quite interesting to look at the in-depths of the hydronephrosis and how they were actually managed, which wasn't very clear in the paper.
And then the majority of patients, more than 50%, was treated with neoadjuvant chemotherapy. What's your opinion about neoadjuvant chemotherapy and trimodal therapy?
As you know, there's no solid evidence behind neoadjuvant chemotherapy and TMT. But if you extrapolate from the evidence from radical cystectomy series, then you should say, as a matter of principle, having neoadjuvant chemotherapy is probably an appropriate thing to do.
Yeah.
And these days, we want to be a bit more selective as well. There's a trial in the UK called Gusto, which is trying to use genomics to identify patients who are more likely to respond to cystectomy alone or IO or chemotherapy. So those are interesting frontiers that hopefully will get some answers, and perhaps even then to decide whether it should be a cystectomy or even radiotherapy.
Yeah, that's a nice trial. Let's wait for those results. Laura, regarding trials in surgical series, is there any news regarding lymph node dissections?
Yeah, the pelvic lymph node dissection. That's important update in the 2025 guidelines, because it's been a strong recommendation for years to perform a pelvic lymph node dissection along with a radical cystectomy. However, the exact extent of the pelvic lymph node dissection has been a topic of debate. And then
should it be an extended, a super extended, or a standard?
A standard, yeah. And then there is the LEA trial and the SWOG S10-11 trial. In the LEA trial, patients with bladder cancer underwent cystectomy, either with a limited lymph node dissection or an extended lymph node dissection. There was a small survival difference in favor of the extended lymph node dissection, but it failed to show significant benefit for the extended one. Then there is a SWOG S10-11 trial, again, patients underwent cystectomy either with a standard lymph node dissection or an extended pelvic lymph node dissection. And in that study, again, no significant difference in disease-free survival or overall survival. But importantly, there was much more morbidity, much more complications in the extended pelvic lymph node dissection.
Yes, and even the mortality doubled.
Yeah. So based on these results, it's now recommended to perform a standard lymph node dissection, as an extended lymph node dissection does not improve survival, but does increase the risk of morbidity.
There is some discussion about the borders of the lymph node dissection. What is a limited, a standard, an extended, and a super extended? Regarding the new recommendation, what do we call a standard lymph node dissection?
Up to the bifurcation of the common iliac artery.
Okay.
Yeah.
So we should go up to that bifurcation, but not any further anymore.
Exactly.
Okay, wonderful. Any other news in surgical series?
Not really, I think. No.
No.
All right.
No, to my opinion also not.
No.
And then the adjuvant treatments?
Yeah.
So there is something new. We have the nivolumab trial, the Checkmate 274.
Exactly. The Checkmate 274 is a phase 3 trial which evaluated the efficacy of adjuvant nivolumab in patients with high-risk bladder cancer after cystectomy, so adjuvant nivolumab indeed.
Yeah, and it was a double-blind study, so patients either got nivolumab or got placebo.
Yeah. And the study demonstrated a significant improvement in disease-free survival for patients receiving nivolumab compared to placebo.
And that led to a recommendation.
Yeah.
So the recommendation is now level of evidence 1B to give patients adjuvant nivolumab. But there's a certain group of patients.
Yeah, in patients who have a PT3 or 4A or node positive
after cystectomy.
After cystectomy, yeah.
And that's also after neoadjuvant chemotherapy, or is that a different group?
Yeah, that's also after neoadjuvant chemotherapy. Yeah.
So, and there's something about the approval. So we have the FDA approval and the EMA approval.
Exactly.
Is there a difference between those two?
Yeah, the FDA approved nivolumab for adjuvant treatment for those high-risk patients, irrespective of PD-L1 expression levels. European, the EMA approval is more specific and endorses nivolumab for the high-risk patients who have more than 1% PD-L1 expression.
Yeah, okay, so that's
PD-L1 positive patients.
PD-L1 positive patients.
Yeah.
Param, anything else in metastatic disease? So we have the results of the enfortumab trial, the EV302, enfortumab vedotin plus pembrolizumab. Can you tell us something about that trial?
Well, really exciting stuff, isn't it? I mean, this is probably the biggest thing that has happened in the recent past. There's an additional survival advantage with the EV-Pembro and patients with metastatic disease.
Because up to now, we gave those patients gemcitabine cisplatin.
Yeah, possibly something that didn't really do anything at all. And, it'd be interesting to see how their quality of life is as well during that treatment.
And Param, can you tell us something about the overall survival benefits?
The overall survival doubled.
It doubled? Okay.
Yeah, with EV-Pembro.
So it was with gemcitabine cisplatin, it was 16 months and it went up to 31 months.
31 months.
Exactly.
Yeah. So Laura, we discussed the results of the EV302 study.
Yeah.
What if patients progress? Is there anything new on the horizon?
Yeah, FGFR testing. So patients should be tested for FGFR mutations or fusions.
And when they are positive?
They can receive targeted therapy.
Targeted therapy, and it will be erdafitinib.
Yeah, exactly.
Okay. Laura, so we discussed surgical treatment, metastatic treatment. Is there anything new on follow-up?
Yeah, definitely. So far, there was no standardized way for follow-up of patients after cystectomy. And now in the 2025 guidelines, we provided a practice-based framework guiding oncological follow-up with imaging, also functional follow-up, checking stoma care, avoiding sexuality, laboratory analysis. So definitely worth checking that out.
In the guidelines.
In the guidelines, yeah.
So Laura, anything we forgot?
I don't think so. No.
No? Bram?
Doesn't look like it. I think we've covered most things.
Then I would like to thank you both for this video podcast. Thank you all for watching and see you next time. Bye.